described about the surgical staging and excision types. These are the intralesional, marginal, wide, and radical. And Kawaguchi et al., which was for the margins, basically thick margin, thin margin. These are the things which come under thick margin. Here we have to see it is joint capsule here, while the joint cartilage is 5 centimeter. And then for thin, it is the fascia, periosteum, vessel sheath, and perineurium. So the next is about the margin status. This is one of the series that was done of MSKCC of 2084 patients, where they said that the local recurrence depends upon the margin positivity and tumor which is more than 10 centimeter and grade. And margin positivity increase the chances of distant metastasis. There's one more group, Scandinavian sarcoma group, which had almost 559 patients, which said that patients who underwent surgery alone, and then the factors affecting local recurrence was only margin and grade, and not the tumor size. And there was no effect of the margin on the distant metastasis. So margin and overall survival have varying defects. Generally, no effect on sarcoma specific survival as such. So then coming to positive margin. Positive margin, if it is a low grade sarcoma and it was planned positive margin because of some critical structure was near it or anything, then the recurrence rates were very low. This is what was told in the study, Gerand et al. But there was high risk of local recurrence when it is an unplanned excision or an unplanned positive margin. And re-excision needs to be done in these cases. So then coming to the trials proper, first is about whether radiation therapy, limb salvage should be done or amputation. So when they started with treatment for sarcoma, it was all amputation in the initial 1970s and 1980s. So then came a first trial that was Rosenberg et al., which was a landmark trial which came in 1982. They had only 43 patients whom they randomized into amputation or doing just a limb salvage followed by radiation. And after this, all the patients received chemotherapy, that is doxorubicin and cyclophosphamide methotrexate. And for patients who underwent limb salvage surgery, received RT 45 to 50 grade. So they found that the patients who underwent limb salvage surgery had more local recurrence rate compared to the patients who underwent amputation, but there was no survival benefit by doing amputation. So thus,
just one question, Dishitha. Chemo both the groups had, right?
Chemo both the groups had. Okay. After amputation, both the groups had chemo. Limb salvage group had adjuvant radiation. So they were trying to do it more locally rather than they were just trying to reduce the radicality of the procedure. So they obviously by doing a minimal surgery, they found the local recurrence was definitely more. But then that did not make any effect on the survival. So then they came up with the thing that limb salvage surgery with radiation is a standard of care, and that's why amputation can be avoided. So now, once that we know that limb salvage surgery is standard of care, then they decided whether adjuvant RT needs to be given in all or it can be avoided. So then there's one more study that is Yang et al., which they had almost 141 patients. Now that we know limb salvage is a standard, should we give RT or we can do without RT as well? But they included both high grade and low grade, and patients who were high grade, they gave chemo RT, and who were low grade, they just gave RT. So they found improved local recurrence rate in both low grade and high grade as well. Again, no survival or no distant metastasis free survival was noted. And the local recurrence was significantly reduced in patients who were high grade. Hence, they came to that thing that adjuvant RT has to be given along with limb surgery. And then first limb salvage became a standard, then limb salvage with RT became a standard. But then they also saw that in low-grade patients, when RT was given, there was high complications and less benefit. So maybe that came up with the concept that in low-grade, maybe we need not give RT in all the patients. Then now that we're giving RT, is there anything more or less than giving an EBRT? So then came the Peisters et al., that where they used brachytherapy. So now in this had almost 164 patients, extremity and trunk both were included. Surgery was done, that is limb salvage, and after that patient was given brachy or no brachy. they found that local recurrence rate was less in high grade lesion, and again no benefit in low grade. So low grade, whether RT needs to be given depends upon whether the resection margin is positive or there are a possibility of recurrence being high. Only then the RT is indicated. Otherwise, surgery is enough. That is what was concluded. And in high grade, there is no we can't exclude RT after doing the limb salvage surgery. Now that we know we have to do limb salvage, we have to do RT. Now, when to give RT, whether to give it pre-op or to give it post-op. So, pre-op RT had its own advantages and disadvantages. Like when we give pre-op, the target volume is very less, and there is improved oxygenation, and then we can also see if it will improve the resectability also of the surgery. But disadvantages was the post-op wound complications was more, especially when it was in the thigh, and the duration of the surgery gets prolonged. And if the patient turns out to be resection margin positive, then you have to give RT again. So this has the disadvantage of pre-op RT. While post-op RT, advantages, we'll know the pathology and then we can decide whether it's a low grade, high grade, and then does it need RT or not. Post-op complications will be less, and that was studied in the standard of care along with limb salvage surgery. Disadvantages is post-operatively you have to cover a larger uh, area because of the edema, post-op changes, and everything. You have to give more doses. Hypoxia of the tumor bed is seen, and the wound complications has been there will be delay in the if there is any wound complications following surgery, then you can't start the RT early. So there will be delay in starting the RT. These were the disadvantages of post-op RT. So then this is the most important study over here, O'Sullivan et al. This is also known as SR2 trial, where they had 190 patients. They randomized them into post-surgery. 94 of them received pre-op RT, 96 received post-op RT, and the patients who had margin positive received a boost as well. So their endpoint was just to see about the wound complications at the end of 3 months. And they found that obviously the wound complications will be more in pre-op RT, and was significantly high. Because of the high this thing, they had to stop, and then the complications were very high when it was a thigh lesions. And late complications like fibrosis, joint stiffness, edema were seen with post-op. But post-op, it was when they followed up further, they said that the patient had a better function at 6 weeks. So when the late effects were analyzed at 2 years, they said 5-year survival was better with pre-op RT, but disease-specific survival was similar whether you give pre-op or post-op. Then, now that we know pre-op, post-op, or after this, then whether we can give any other forms of RT other than EBRT. Like we had brachytherapy, there's one more IMRT was introduced. This was introduced by RTOG 0602. This reduced the radiation field, thereby only 10.5% of the patients had wound complications when you give pre-op RT. Then brachytherapy we've already discussed, Pisters et al., who said that giving brachytherapy had an advantage in high grade, local recurrence rates were reduced, but when the overall survival was same. And the benefit of giving brachytherapy is it can be given in high grade lesions which are less than 10 centimeter negative margins, and even previously irradiated recurrences also we can give brachytherapy. So now that was about limb salvage surgery, radiation, and now after that, should we give adjuvant chemotherapy? So initially there were a lot of RCTs with a lot of conflicting results. When some had benefit, some there are like hundreds of it if you see it in Devitaka table as well. But then the largest RCT was SMAC meta-analysis. SMAC meta-analysis had 1,568 patients. It included 114 RCTs, and they saw what was the efficacy of giving adjuvant doxorubicin-based chemotherapy after surgery. So it had better local recurrence-free survival and distant-free survival, but overall survival was not significant. Whether irrespective of the stage, grade, resection status, it didn't matter. But it came out that doxorubicin-containing chemo has the best benefit of the all. And there was 10% reduction in the distant metastasis and 7% absolute survival benefit. Then they had an updated SMAC meta-analysis which came in 2008. Other than the 14, they included 4 more recent trials, and these they used ifosfamide with adriamycin. Now there they knew that doxorubicin containing chemo is the best. Among doxorubicin, again, IA regime had a better OS benefit and better local control and recurrence-free survival with chemotherapy, ideally of 5 to 6 cycles. So this was the update with SMAC meta-analysis. Similar 2 more trials. One is EORTC 62931, which had almost 351 patients, where they compared after surgery. Now, is it necessary to give chemotherapy or we can just observe? And both the patients received RT. Limb salvage with RT was the standard over here. After that, whether you need to give chemo or you don't need to give chemo. They found that recurrence-free survival and OS was similar, but the problem here was they included both extremity as well as non-extremity. So non-extremity patient survival will obviously be more worse than compared to extremity. So this had a combined group. But later, few years later, after that, recently, they re-stratified it. And they found that the benefit with disease-free survival was more than 60% when it is a high-risk patient. Then there's one more study, that is Italian cooperative trial, which is a non-inferiority trial in which they gave arm 1 had 3 cycles. The cycles are seen here, IA followed by surgery, that is neoadjuvant, or they give 3 cycles surgery and then another 2 cycles. It was a non-infrared. It was almost similar, and this included only the high-risk patients like grade 3 and 4 lesion more than 5 centimeter. It was a recurrent tumor. So that was about giving adjuvant chemotherapy. Now that we know that chemotherapy does have a benefit in high-grade lesions, recurrent lesions, large lesions, and everything, high-risk lesions basically, is it beneficial to give it pre-op if you can give it before doing the surgery itself? So there's 2 studies. The first study was a negative trial. This is important. Bronchi et al., which was Italian study done in 2008. Here, what they did was it was a histology-driven chemotherapy. For every histology, they gave a different chemotherapy. Overall, IE was the standard chemotherapy which was given. Other than that, like myxoid liposarcoma, they gave trabectedin. Synovial sarcoma, they gave high-dose ifosfamide. So every specific histological type, they tried different. So they did not find any superiority by giving these histology when they compared it with the standard chemotherapy. But this was beneficial. They found giving trabectedin in high-grade myxoid was found to be better beneficial. Otherwise, overall, IE, that is our ifosfamide and epirubicin or erythromycin, was superior compared to giving all this. And they included only the deep-seated more than 5 centimeter high-grade lesions. So this is again the same. Here it is the Rosenberg et al., which first said about compared amputation and limb salvage surgery, said limb salvage with RT is the standard of care. Mr. said about the brachytherapy. Young et al. Said, should we give RT or not, which compared post-operative and came up with that post-op RT is required. Then there is O. Sylvan et al., which compared when to give RT, whether it is pre-op or post-op.
इसमें ओएस बेनिफिट था क्या ओ सुलिवान में like on long term you telling?
No, there was no OS benefit in that.
O Sullivan, I think last line you told ki there was better OS in
so
pre-op.
The thing was their primary endpoint was to check only for wound complications, whether you give pre-op and post-op, is it going to affect the wound complication? That was their overall thing. But then that secondary output, when they compared later, they saw that 5-year survival was better with pre-op, but disease-specific survival did not matter, whether you give pre-op or post-op. So that was like a secondary outcome they just observed, but the primary was to see about the wound complications associated
so
with it.
There was benefit with pre-op party, was survival.
Later when they saw.
Okay.
So this is it. Retroperitoneal, that was about soft tissue sarcoma, extremity and truncal. Now about the retroperitoneal sarcoma, surgical treatment is a standard of care, except when it is inoperable, when it is involving the SMA, SMV, or suprahepatic IVC or metastasis. Now, in surgical treatment, how much should we do? Whether we should do a compartmental resection or we should just do a wide excision. There were 2 retrospective data for this. retroperitoneal sarcoma, the cases are very less, so that most of them are just a retrospective data study. That is, one is Bronca et al. And TARPSWG. So what they found that whether you do compartment or wide excision, Bronca et al. Had 331 patients. 20% difference was noted in the recurrence and survival, and benefit was seen only in grade 2. That is, in grade 2 and grade 2, 1 and 2 tumors only. The compartmental dissection had 20% difference in recurrence free and survival. But they also saw that in the other study that compartmental excision was associated with high morbidity and mortality as well, and R0 R1 rates were better when you do compartmental resection. R0 rate will be better, but the complications were more. So what was concluded that when it is a well differentiated and low grade or a de-differentiated, these are basically the good liposarcomas, there is benefit from doing radical surgery because these are low grade. When they recur, it is the local recurrence which is the most common site of failure. So in these cases, doing a compartmental resection was beneficial. But in high grade lesions, multifocal, they are usually multifocal and they have high recurrence rate. So doing radical surgery is not as much beneficial because they're bound to recur invariably. And
this is for retroperitoneal or limb?
This is for retroperitoneal. I'm talking about retroperitoneal. Only
compartment, like I am not aware about compartment concept.
Compartment is when there's a retroperitoneal fat is involved. If it is involving the surrounding structure or anything, all the fat in and around it comes. If it is involving the kidney, then even the nephrectomy will be included in compartmental resection.
Okay, the unblock they are saying.
And block completely. So here wide excision is just removing the tumor R0 margin.
Okay, in limb though we have that is the compartment. In retroperitoneum, yeah. Okay.
Retroperitoneum, along with the adjacent structures and the organs which come in and around, usually it is the kidney. So that is also removed along with it. That is compartmental.
Okay.
Okay. So that's what. So when it is high grade, there's no advantage of doing compartmental because they're bound to have a recurrence. Unnecessarily, you'll have a lot of morbidity associated with it. So that is it. Then about giving neoadjuvant treatment, this has found to be benefit when R0 resection is difficult, like they will increase the local control and it will reduce the bowel toxicity, and but higher RT dose was more effective, and the conversion of unresectable to resectable. So this is just one study over here in neoadjuvant RT, that is the STRASS-1 trial, which is more important. So RCT phase 3, where they compared just doing surgery or you give neoadjuvant radiation, after that you do a surgery. So radiation was almost 50.4, and the outcome they compared was abdominal recurrence-free survival, because retroperitoneal sarcoma is more prone to recur and it's usually in the local site itself. So they found the abdominal recurrence-free survival and OS was similar, whether you give RT and then operate or you directly operate upfront. But the local recurrence was 2 times in surgery alone group. And but there was more complications associated with RT group, obviously, because there are a lot of structures, vital structures around it. So the side effects were also more. That was about neoadjuvant RT, that is STRASS-1 trial. Then coming to this is about the same. In STRASS-1 trial, what they did was there was later a subgroup analysis that was done. They found that the improved recurrence-free survival was noted in this low-grade ones and not the high-grade. Just like how we discussed before about doing compartment and this thing, the low-grade there was improved recurrence-free survival by giving adjuvant RT. But for high-grade, it didn't matter whether you give neoadjuvant RT and then do a surgery or just do the surgery. But it was associated with high post-op complications. It's usually not a standard of care. When STRASS-1 was about neoadjuvant RT, is about neoadjuvant chemotherapy. It is ongoing. It is expected to complete in 2029, where they give 3 cycles, and the 3 cycles here we know the standard of care is IA, followed by surgery, and one more is PSWG study where they included high-grade retroperitoneal. They saw that there was a fair response to chemotherapy. No PCR was seen in the study as well. Then there was, now we know about neoadjuvant RT, that is TRAS1 trial, neoadjuvant chemotherapy, that is TRAS2, but then there is, to combine CTRT, there is no prospective trials as such. Then about the adjuvant. Adjuvant radiation is not indicated if you have done a R0 resection or an R1 resection. If it's a R2 resection, then radiation is advised. There is a database, this is National Cancer database of 9,068 patients where they did more than 2,000 patients underwent surgery alone versus remaining underwent surgery followed by adjuvant RT. They saw OS was better. This was when it is R2 resection or a resection margin was positive, only then. Chemotherapy, that's it. This is about retroperitoneal sarcoma, basically. We have to revise or we'll go ahead.
Like how much time you will take for further trials?
I have melanoma. That should take another 15-20 minutes at least.
Okay. So we can revise them briefly, maybe.
Okay, yeah. So in soft tissue sarcoma, what are the things we need to remember? One is this Eneking concept. Next is the Kawaguchi concept. I think this all of us know. And then about the most important is the Rosenberg et al. This is the one which laid for limb salvage surgery with RT became the standard versus amputation. So this, once we know limb salvage became the standard, the next came do all need RT or versus no RT? For that, it is Yang et al. So in RT, then can we give brachytherapy? That was Pisters et al. So this was related to limb salvage surgery. After that, RT versus no RT was Yang et al. Brachy was Pisters. Okay, so this, after that, pre-op RT and post-op RT, to compare, we had this SR2 trial, whether we should give pre-op or RT and how much was the wound complications associated with it. Then came here, this is most important, the SMAC meta-analysis. This is for adjuvant chemotherapy. And in this, they said the doxorubicin-based chemotherapy were the standard of care that had the best benefit of all in present RCT. Then the meta-analysis was updated. In that, again, they found doxorubicin-based, especially the efosfamide adriamycin group had the better. Along with this, there were two more studies which compared adjuvant chemo, that is EORT 62931 or the Italian cooperative trial. Then there was one more which was histology-driven neoadjuvant chemotherapy, that was Gronkai et al. So first it was about surgery, Rosenberg. Then it was Yang et al. Whether we should give chemotherapy or not. Then it was Pisters, which was about whether giving brachy was beneficial. Then it was about giving adjuvant chemotherapy, that is SMART meta-analysis, Italian cooperative group, and the EORTC study said IA was more beneficial. And then about giving neoadjuvant chemotherapy, it is Gronkai et al., which said IE itself is a standard chemotherapy and giving specific histology-wise chemotherapy is not beneficial. Okay, and in retroperitoneal sarcoma, this Gronkai et al. And PSW, which was first about the surgical trial, that is being compartmental versus wide resection, in whom compartmental is beneficial and whom we can just do wide excision. And after that came whether, because this retroperitoneal sarcomas, they're usually bulky lesions, should we downstage them? So neoadjuvant treatment. In that, in any neoadjuvant treatment, there's neoadjuvant RT, that is TRAS1, and the neoadjuvant chemotherapy, that is TRAS2. Okay, so TRAS1 said that giving neoadjuvant RT was not beneficial as much, though local recurrence was 2 times in surgical alone group, local recurrence was less, but overall survival and abdomen's recurrence-free survival did not differ much. Unnecessary, there were a lot of complications that was associated with it, with giving RT preoperatively. Next was this was for neoadjuvant chemotherapy. And next about adjuvant treatment. Adjuvant chemotherapy, there's no definitive advance, but anthracycline phosphomide has shown to improve the survival. But for adjuvant RT, only when it is R2, when there's positive, then it has shown that there was beneficial. This was just based on some database. There's no RCT. Okay. Melanoma. We'll start with melanoma. Here there are a lot of trials.
Start. नाइसली
So,
कंसाइज सॉफ्ट टिश्यू अच्छे से कंसाइज किया. इतना हम लोग तो सफर कर रहे थे उस टॉपिक में.
no, there's no point studying so much. This what is relevant is only few. So, but melanoma is very confusing. I have studied. I've still not understood half of the stuffs to remember. I feel. So,
डॉक्टर राकेश हेल्प करेंगे बाद में. इससे कुछ निमोनिक्स और कॉमेडी ट्रिक्स बनाए हुए हैं.
I think that is really needed in melanoma. So melanoma, the standard treatment we all know, wide excision of the primary, and the treatment here is whether it is a thin melanoma, whether it is an intermediate thickness, or whether it is a thick. These are the things that will decide, and the other things are whether there is a nodal lymph node recurrence, whether there is in-transit mets, whether there is distant mets. Based on this, they can be divided into stage 1, stage 2. Based on the tumor thickness, it is thin, thick, or intermediate. And then there is stage 3, which is more of regional lymph node, in-transit mets, satellite mets, all recurrence, all this come under stage 3, and stage 4, where there are distant mets. In short, this is, I'm just telling so that we can go ahead with the discussion. Clinical trials first that we know in stage 1, stage 2, surgical resection is the wide excision, but how much of the margins to remove? So for this, there were trials. The most important is WHO melanoma program trial number 10. It's an RCT which had 612 patients. Here they include only 0 to 2 mm thickness patients were included, and they compared whether we should do 1 centimeter or 3 centimeter or more. And they found that there was no difference in the local recurrence. So whether you do 1 centimeter or you do 3 centimeter, the local recurrence rate did not matter, nor did the OS. So they concluded that why do more? 1 centimeter margin is safe enough. The lesion is less than 2 mm. So along with this, there were 2 more studies which also said the same thing. This is a French cooperative surgical trial. It's also given as European trial in few places. Again, they also included 0 to 2. They compared 2 versus 5. So again, they found there was no difference. Even if you do 2, it is the same with the local recurrence and overall survival. Then the third is the Swedish cooperative. This was again further 0.8 to 2 mm, 2 versus 5. Again, they also. So all 3 studies concluded that when the melanoma is up to 2 mm thick, 1 to 2 margins are adequate. So there's no benefit of doing wider margins. But to be noted that WHO melanoma program trial, French cooperative and Swedish cooperative, all of them included 0 to 2 mm itself. That is thin and intermediate. So now what about the thick lesions? So,
नहीं उसको थिन मान के चलो तो याद करने में आसान रहता है. इंटरमीडिएट इज 1 to 4 ना, तो you include मतलब in your mind you remember it is thin melanomas 1 centimeter margin is enough. You write 0 to 2, but in your mind you remember only thin melanomas, क्योंकि that is how it becomes easier.
Easier, yeah. True. So this is 3 trials for the thin. So next is whether in the more advanced. So what about lesions which are more thick? So in this we have intergroup melanoma surgical trial which included 1 mm to 4 mm this thing. So basically this is intermediate thickness we are talking about. So now that we know here that 2 centimeter is enough for the thin lesions. So is that enough for intermediate? So 2 centimeter versus 4 centimeter. Again, they found there was no difference. 2 centimeter was more than enough in melanoma, and the local recurrence rate was almost less than 1% in these. One more study is the British cooperative group trial. Again, this was for all lesions which were more than 2 mm, and 1 centimeter was no difference was found again. but there was increase in local recurrence and worse melanospecific, especially when patients were done with 1 centimeter margin. So they found that doing 1 centimeter, there was increased local recurrence. So we have to do a little more than 1 centimeter, maybe in the lesions which are intermediate and thick. But the thing is, none of these patients had undergone sentinel lymph node, so the groups were not equally balanced. So, because as per the present guidelines, the thick lesions should definitely undergo, intermediate lesions we are supposed to consider SLNB when the thin lesions do not need. So, that was not done in this trial. The next 6th trial will be the MELMA trial, which is ongoing, where the 1 centimeter margin is adequate for all the lesions, or minimum 2 centimeter for these high risk melanomas is required. So this is about the margins. So for the thin, if we consider this as thin, then the 3 trials, WHO melanoma program trial, French trial, and the Swedish trial, all said that 2 mm thickness is enough. 2 mm margin, all said that 1 to 2 centimeter margin is enough for 2 mm thick lesions. Next, for what about something that is little more? There were 3 more trials. There is intergroup melanoma surgical trial, British cooperative trial, and MELMA trial. So these 3 were for lesions which are more than 2 mm. So this is just the same thing. These 6 trials that we have to remember. So the one in the red are all thin lesions, and the one in the blue are all thick lesions, intermediate and thick both. So then now that was about the margins. So in melanoma, the most asked are specifically they have asked about the trials related to margin, related to sentinel lymph node, related to targeted therapies and immunotherapies. So the next being the trials related to sentinel lymph node. So here we have again 3 trials. So we studied 3 trials for thin lesions, 3 trials for intermediate and thick lesions, 3 trials for sentinel lymph node. That is multicenter selective lymphadenectomy trial group, that is MLST1. Here they compared whether now there is a melanoma, we know that how much margin we have to remove, whether doing a wide local excision is enough or we have to do sentinel lymph node as well. They found that there was no difference in melanoma specific survival, but in patients with nodal metastasis detected on SLNP had a worse survival compared to patients who had negative sentinel lymph node. That is, when whether you do wild local excision, there was no difference between these two. But in patients who underwent wild local SLB, whether it is positive or negative, the patients who had negative had a better survival. Patient who had positive had a worse survival. So that in turn, and patients with nodal metastasis identified on sentinel lymph node, and if they were removed, they had improved survival compared to patients who underwent only wild local excision. And this was criticized because since randomization was not done at the onset of the surgery, the onset was whether to do sentinel lymph node or not to do sentinel lymph node. But then they found out that later when they further randomized into patients who had positive and negative, that's when they found the prognosis was affected. So then what is the role of complete lymph node dissection in patients who had positive sentinel lymph node biopsy? Only 20% of the patients who had positive lymph node, when you did a complete lymph node is positive lymph node, when we did a complete lymph node, only 20% of them more disease was detected. But all of the 100 patients who underwent this complete lymph node were associated with a high risk of morbidity. So unnecessary, all of them will have bleeding, wound complication, lymphedema risk, but while only 20% will have more disease. So positive disease when you get in complete lymph node was definitely a prognostic value, but it did not benefit the survival. Patients with no disease and complete, or the patient in whom when we did a complete lymph node dissection and no disease was identified, they were also found to have a distant metastasis at a later time. So it was not much beneficial of doing a complete lymph node dissection. So this was MLST 1. So next, the second trial in sentinel lymph node was TCOG SLT trial. Here, they enrolled patients with overall more favorable prognosis. They found that 68% of the patients who were found to have sentinel lymph node were the ones who had low tumor burden, that is less than 1 mm or less. That is basically micromets were found. in these patients. So basically, distant metastasis-free survival at 3 years, whether you observe these patients who are sentinel lymph node positive or you do a complete lymph node dissection, did not matter much, because overall, when you find sentinel lymph node was positive, it was all micromets in almost 68% of the patients. So it didn't matter whether you do observation or complete lymph node dissection. Next is MLST2. Here, what they did again, for patients who are positive for sentinel lymph node, they randomized into whether doing observation is enough. Observation is with USG, and on surveillance the patient is put on, or you have to do a complete lymph node dissection. Patient with observation also, they found that the nodal only failure rate, that the patient recurring with a nodal recurrence was 7%. But when you do complete lymph node, there was no survival benefit as well. So it is not routinely done. The conclusion is CLND is not routinely done after a positive lymph node. And in high risk patients and patients who are extranodal dissection node is positive, we need to discuss with the patient that CLND may be beneficial, but it comes with its own morbidities. So with this, there were 3 studies that we studied for SLNP, that is MLST1, MLST2, and DCOG. So what is the rationale of doing SLNB in melanoma with these studies? One, negative SNB, which means it's a good prognostic indicator. You can comfort the patient. You can decide that this is a low risk patient and just put the patient on surveillance. If it is a positive SNB, then you know that there is high risk of recurrence, and thereby you can stratify the patients to consider for adjuvant treatment. So adjuvant treatment can be either BRAF or MEK inhibitor or immunotherapy. And in patients who have microscopic satellite lesions, that is this N2C, which comes in stage 3B, these are the patients who have no lymph nodes, clinically palpable lymph nodes, but then they have microscopic satellite lesions. And if you do a sentinel lymph node and you detect that the lymph node positive, then it becomes an occult lymph node. So they get upstaged. And thereby you can identify the patients by risk assessment for these patients. And the sentinel lymph node, it is well tolerated, low risk of lymphedema, so it is safe to do as well. So how do we select patients for sentinel lymph node? I'm just going a little more than the trials because I thought it was important. Sentinel lymph node has been repeatedly asked in melanoma. It is recommended for patients who are having more than 1 mm thickness, but NCCN gives more than 1 mm to 4 mm. It is considered more than 4 mm, you have to do it. So basic. And for thin melanomas with ulcerations, that is thin melanoma is T1A, with ulcerations it become T1B. This we have to consider SLNB. That was about margins and sentinel lymph node. Then is there a role for radiotherapy in primary melanoma? So primary treatment for melanoma is excision. So radiation is rarely used. They are used in 2 situations. One, as a palliative intent in patients who are not fit for surgery or for systemic treatment, has a palliative, you just give radiation. Or in lentigo melanoma or lentigo maligna melanoma, which are usually seen in elderly, chronically sun-exposed patients, and they're usually seen in the head and neck, where excision is very challenging and it is difficult to do sentinel lymph node as well in these areas. So and therefore they become unresectable, but they have very low risk of metastasis. So in these, as an alternative to non-surgical methods, radiation can be given. So then that was about stage 1 and stage 2. So now if you come to stage 3 and resectable stage 4, so in these patients, whether there is role for giving neoadjuvant therapy, downstage it, get a pathological and radiological response, and then if you can do a surgery. With this concept in mind, 2 things. One is targeted therapy and immunotherapy. These were the 2 things that were checked. And targeted therapy, that is especially when the patient is BRAF V600E mutation was positive, neoadjuvant chemotherapy had a high response and low chances of relapse. In this, we have 2 studies. One is Vargo et al., which was published in Lancet 2018, where what they did was dabrafenib and tremectinib. This is only in BRAF positive patients. Were given for 8 weeks. Then surgery was done, and followed by adjuvant treatment was given versus doing surgery upfront. And they found that there was 85% of radiological response and 58% of pathological response was noted in patients who received neoadjuvant targeted therapy. So because of there was a dramatic improvement in the event-free survival, that is almost about 19.7 months compared to 2 months. This was FDA had approved this for neoadjuvant targeted therapy. The one more study is NeoCombi study. NeoCombi study, they gave again dabrafenib and tremectinib for 12 weeks. Surgery, this is a open label single, there's only one arm in this. And after that, adjuvant therapy. In this also, they saw that the response rate was almost 100% and complete response was seen in 49% of the patient. And all patients underwent surgery, and the side effect is usually pyrexia and not much more. So it is safe to give it. So this is for stage 3 and resectable stage 4. Role of neoadjuvant. Neoadjuvant with BRAF, that is Vargo et al. And NeoCombi study. And now that was about targeted therapy. Now, what is the role of immune checkpoint? In melanoma, it is always systemic therapy, immune checkpoint, and targeted therapy. 3 things that we have to study. So, immune checkpoint, this includes CTLA4 inhibitor, that is ipilimumab, or anti-PD-1. So, initially, there was a study which showed just single dose anti-PD-1 followed by adjuvant. There was a response rate of 30%. But then further, when they studied, they gave combined nivolumab with CTLA4 ipilimumab. But the nivolumab dose was 1 mg, and this was the mg. This was stopped because there was a lot of grade 3 toxicity that was associated. This is mainly because of the high dose of ipilimumab. So then came Opacin Neo trial. Here they reversed it. They gave low dose of ipilimumab, that is 1 mg, and nivolumab, they raised the dose, that is 3 mg, when it was 1 mg over here. And they decided this is the optimal dosing regime because 57% of pathological response rate was noted, and even the grade 3 toxicity that was seen over here was decreased. So if we're giving a neoadjuvant immunotherapy, then this became the optimal dosing regime. And they also saw that patients who received neoadjuvant, they had more complete response or near complete response with targeted therapy or immunotherapy had improved outcomes. And especially patient who received immunotherapy had superior PCR compared to the that is dabrafenib and tremectinib. Compared to that, these patients, nivolumab patients, had a more pathological response, and more relapse-free survival also was noted. So after this, I have not studied in detail. I was just trying to finish up, but I have added few just to complete the topic. So if I'm missing anything, please let me know here. So now that is stage 3 patients, we have given neoadjuvant. We have seen the role for neoadjuvant. Then we operate the patient. So what after surgery? That is when the lymph node. Stage 3 is mainly about lymph node mets, local recurrence, regional metastasis, or in transit metastasis. So we have resected them. After resecting, what is the role for giving adjuvant treatment? For that, we have this 4 trials basically. Combi Ad, so Checkmate 238, and Keynote 054, and SWOG S trial. So in Combi Ad, what they did was now we saw that dabrafenib and tremectinib was definitely beneficial in neoadjuvant setting. So in adjuvant setting, they again use the same combination with placebo. And here it is stage 3, that is N1A more than 1 mm or higher, and M0 were included. They saw that recurrence-free survival was dramatically increased in this group with almost 52%. And the next is Checkmate. But the stage 3, 2C and stage 3, the similar group was included over here. And here, when they used dabrafenib and tremectinib, that is TKI was used, they compared within the same group, they compared with the role of IO, immunotherapy. That is, they used pembrolizumab versus placebo. Again, they found that there was local recurrence-free survival was 43% lower in this group. The other OS and all is not reached yet, but they definitely found that pembro was beneficial. Immunotherapy was beneficial in this group as well. These are the same set of patients that was used. Next being when they used N2A and higher patients, or it was a resectable F1, that is the resectable stage 4. Again, they compared. Here, it was only for immunotherapy. They compared whether you give a single agent. Nivolumab was compared with CTLA4 ipilimumab. They found nivolumab was better. It had a better recurrence-free survival at 4 years, and median overall survival was almost recurrence-free survival was almost 52 months when compared to ipilimumab, which was 24 months. Similar set of patients, but now they used pembro instead of nivolumab and ipilimumab or interferon alpha. The arm 2 was almost the same. Instead of nivolumab, they used pembrolizumab here. Again, they found that pembrolizumab was also, there was recurrence-free survival was better. Almost 23% improvement was noted in these group as well. This is for stage 3 as an adjuvant treatment. So 4 trials over here, CombiAd and Keynote 4, which included N1A and M0 patients, and Checkmate 238 and SWOG-S, which included resectable stage 4 as well, where they compared nivolumab with ipilimumab versus pembro and ipilimumab. Both the places they found IO, that is pembro and nivolumab, was beneficial. So now this is for stage 4. Stage 4 patients. Stage 4 patients, what is the role of immunotherapy? That so we have 3 studies over here. Check Keynote
SWOG, they tried to compare Nivo AP with Pembro.
SWOG, they
interferon.
No, they compared pembro with ipilimumab. That's
interferon
all.
alpha.
Alpha.
Okay, and Pembro was found better.
Yeah, pembro was found better. While in Checkmate, it was nivo with ipilimumab, and ipilimumab was found better. So the
दोनों ही PD1 है ना, दोनों same category में PD1.
Yeah, they both are same. They just compared 2 drugs of this thing.
तो चेकमेट चेक कर रहा है, वो दोनों को चेक कर रहा है, उसने प्लेसिबो नहीं लिया है, ये अच्छा बात है.
ठीक है, they were just comparing PD1 versus CTLA4. So now we know that immunotherapy has a role. So now we compare among the two which one we can give, whether we have to give PD1 or CTLA4. And the subset of patients was same group of patients they included in both the study. And then they compared the 2 drugs of PD1. So I don't know if you want to remember interferon alpha, we can just remember arm 2 was ipilimumab. So they compared PD1 with CTLA4. Okay, because interferon alpha, after all this targeted therapy and immunotherapy has come, interferon alpha has almost become outdated.
गायब हो गया.
So that was that. And when the other 2 trials are CombiAd, it's a I remember it as combination AD, that is dabrafenib, and whenever you give dabrafenib, this comes in combination with it, trabectinib. So that's how I remembered CombiAd.
एक्चुअली हम लोग ने ऐसे याद किया था, जो जिराफ ब्राफ है ना, वो जिराफ है. तो जो ब्राफ है वो जिराफ है, तो जिराफ का कॉम करना है. तो जब तुम उसका नियो एडजुवेंट में पढ़ती हो तो वो नियो कॉम भी आता है, जब वो एडजुवेंट में पढ़ती हो तो कॉम भी ऐड आता है. ठीक है, और उसके बाद वाले में शायद कॉम डी भी आता है. डिस्टेंस में कॉम डी भी आता है. हाँ, तो वो तो जो ब्राफ है वो जिराफ है, और जिराफ का कॉम करना है. तो नियो एडजुवेंट में नियो कॉम भी है, एडजुवेंट में कॉम ऐड है, और डिस्टेंट में कॉम डी है. ठीक है, वो जिराफ का एक पूरा कहानी है, वो जिराफ का भी बताएंगे. मॉलिक्यूलर में वो डॉक्टर राकेश बहुत अच्छे से बताते हैं, उससे सुनेंगे.
अरे क्यों मजे ले रहे हो मेरे?
अरे यार, वो सीडी वाला अच्छा है ना, सीडी लेके आता है फिर टीआरपी.
ये सबकी रैगिंग करती है, बता रहा हूँ.
हाँ, ये तो सही बोल रहा है भाई.
तो पहले इसका कंप्लीट हो जाने दो, फिर वो पढ़ेंगे.
We're just done. We're just last two more. So immunotherapy in stage 4, that is checkmate, keynote, and relativity. Here, this is for now for a change. We have a new name because relatimab is also over there. It's not just Pembro and Nivo. So keynote, as we know, it is Pembro versus CTLA4 again. And they found that Pembro was definitely more beneficial than giving CTLA4, and progression-free survival was also more, 8.4 months over here. So there is OS benefit and there is PFS benefit as well, giving
एंड
pembrolizumab.
एक और मेरा एक पर्सनल एक्सपीरियंस है. देखो, जो इम्यूनोथेरेपी है ना, द इम्यूनोथेरेपी मेटास्टेटिक सेटिंग में पहले आई थी और अर्ली सेटिंग में बाद में आ रही है. तो थिंग इज कि जो स्मॉल नंबर्स हैं 6, 67, दिस आर इन मेटास्टेटिक सेटिंग, एंड बिग नंबर 238 एंड द बिग नंबर्स आर इन अर्ली सेटिंग. अगर तुम इसमें कंफ्यूज हो रहे हैं कि कौन से नंबर हमको लिखने हैं, तो ऑलवेज लाइज स्मॉल नंबर इन मेटास्टेटिक सेटिंग एंड बिग नंबर इन अर्ली सेटिंग.
So, and then the other one is checkmate 067. Here they used a combination instead of whether we should give it in combination with CTLA4 or we give it individually. They compared these three arms and they found that giving combination was definitely had a better progression-free survival, and there was also OS benefit and PFS benefit rather than giving just nivolumab and just ipilimumab. Next is, this is here we have a newer one. Nivolumab is the relatimab versus just giving nivolumab. This also found that it had a better PFS. Median PFS overall has not yet been reached. So this was in the distant. And one more, that this was about immunotherapy. Now about the targeted therapy in distant. So in targeted therapy, we have to first check if the patient is BRAF 600 patient is mutant to it or not. If the patient is BRAF 600 positive, then we have all this trial. We have COMBI-D, COMBI-V, COBRIM, and Columbus. 4 trials to remember here. COMBI-D is D, that is basically dabrafenib. This, if we consider as one arm, it is comparing with D, that is dabrafenib. In COMBI-V, again it's the same arm which is comparing with vemurafenib V, that is COMBI-V. COMBI-D and COMBI-V, and again it found that these combinations were always better. They had a better OS and better PFS. Combination always better rather than giving just one, in short. And then the next here, it is COBRIM. COBRIM was vemurafenib with cobimetinib versus vemurafenib alone. Again, the combination had a better PFS and better OS, that was noted. And Columbus had 3 arms where they used encorafenib, bimetinib, encorafenib, and vemurafenib. Again, here the combination was better, median PFS, but the rest of the arms are not reached. So this is about distant metastasis, that is stage 4, targeted therapy, 4 trials, COMBI-D, COMBI-V, where the combination dabrafenib, trametinib versus dabrafenib, or COMBI-V is versus vemurafenib. And then there's COBRIM and Columbus. And in immuno, you have keynote 006, checkmate 067, and relativity. 3 trials over here. And then in stage 3, after surgical resection, stage 3 and resectable stage 4, this is resectable stage 4, the after resecting, about giving adjuvant treatment, we have COMBI-AD, checkmate 238, keynote 054, and SWOG. So this was about that. And in neoadjuvant setting, neoadjuvant targeted therapy, we have Vargo et al. And NeoCombi. And in checkpoint inhibitor immunotherapies, we have OPACIN Neo trial. So this was about targeted and immuno in neoadjuvant setting, and in stage 3 and stage 4 resectable and distant metastasis. That's it. There's one trial in basal cell carcinoma about giving in that hedgehog pathway mutation is present, then the vismodegib as a role. I'll just add it later and share. Other than that, I don't think in non-melanoma there's any trials.
नहीं, इससे ज़्यादा श्रद्धा भक्ति नहीं बची है भाई. डॉक्टर राकेश पढ़ाइए ना मॉलिक्यूलर।
अरे मजे मतलब मैं वो
अरे
शेयर
यार
कर दूंगा। बढ़िया, नाइस डॉक्टर दिशिता, अच्छा पढ़ाया आपने।
मजे नहीं ले रहे। एक जिराफ होता है, फिर वो सीडी लाता है, फिर टीआरपी बढ़ती है ना उसकी।
हाँ वो उस दिन पढ़ाया था यार फ्लो में, अब पढ़ के बता दूंगा या तो
आपको
तो
याद
आपके
नहीं है
पास में
क्या?
होगा ना।
So in melanoma, it is basically the questions that have been asked is the molecular biology, then the sun exposure, the etiology, how it is classified based on that CST, and then it is margins, sentinel lymph node, and this targeted and immunotherapy. I think other than this, if we study the molecular biology and the etiology part, melanoma will be over.
एक्चुअली
So
ये
all that has
इसीलिए
been
आता है
asked.
कि लोगों को बुरा लगे, क्योंकि इतने सारे ट्रायल को याद तो कर पाएगा नहीं। कुछ फील बैड कराने के लिए भी तो एग्जाम आना चाहिए ना, फील गुड के लिए नहीं आता।
Is there anything I have to add? Because the stage 3, stage 4, like since last night I've been just studying in rush to just wind up for today.
नहीं, हम
Anything else
लोग
I have
ने
to
इतना
add
ही
for this?
पढ़ा है, मतलब इट्स लाइक इतना ही पढ़ा है, पर हम लोग सिर्फ 2 ट्रायल्स, मतलब अभी रिलेटिविटी वाला ट्रायल तो नहीं लिखने वाली हूँ मैं। एक 6 और एक 67, 6 और 67 वो बन भी रहा है ना। एंड की नोट का नंबर चेकमेट से पीछे चल रहा है, ठीक है। तो 6 एंड 67, और ऊपर की नोट इज 54 एंड 230। तुमने चेकमेट 238 बता ही दिया है। अब स्वॉग से तुम्हारे पढ़ाने से मुझे स्वॉग भी अच्छा लगने लगा, पर उससे पहले मेरे को स्वॉग पे इंटरेस्ट नहीं था, तो आई वाज फोकसिंग ऑन चेकमेट एंड की नोट ओनली।
SWOG you can remember because you have to just compare it with checkmate. Same patients, instead of nivolumab you're giving pembro. That's it. Just remember SWOG,
हाँ,
even
तो
if not number.
एक्चुअली दे हैव आस्क्ड एक बार, अभी जो हम लोग के फैट में क्वेश्चन आया था, अब मेरे को ये याद नहीं है कि फैट वालों ने मेटास्टेटिक पूछा था कि एडजुवेंट पूछा था, क्योंकि तब उतनी अक्ल नहीं थी। बट दे हैव आस्क्ड समथिंग फॉर द कंपैरिजन ऑफ ये CTLA4 इनहिबिटर्स एंड ये अपना पेम्ब्रोलिज़ुमैब और इमिलुमैब के बीच में हमको ट्रायल्स।
Yeah, there's a question in exam also where they've asked to comparing those two.
तो उसमें आप ये SWOG वाला ट्रायल लिख सकते हो, बिकॉज दे हैव कंपेयर्ड 2 डिफरेंट क्लास ऑफ ड्रग्स।
Yeah, SWOG and checkmate.
चेकमेट तो एक ही क्लास के अंदर 2 ड्रग्स को कंपेयर कर रहा है ना,
नहीं,
से पेम्ब्रोलिज़ुमैब नहीं, निवो
that's what I was telling. This is CTLA4 ना।
अच्छा, हाँ हाँ हाँ
You're comparing PD1
विद
with
CTLA4, तो एक ये
Here
आएगा।
also it is PD1 with CTLA4, just that different drug in
तो हमको
PDL1.
इन दोनों के
nivolumab,
कंपैरिजन
pembro.
में ये 2 ट्रायल्स लिखने हैं।
And the type of patient included is also the same. You just have to remember checkmate 238 was because it's checkmate, it is nivolumab, and SWOG for a change, it is not keynote, it is pembro. For pembro, it is not keynote, it is SWOG here.
ठीक है, बढ़िया। चलो, सी यू टुमारो मोहन का एरेक्टम, वो भी बहुत बड़ा टॉपिक है।
Yeah.
चलो बाय।